as you can see, Matt and I share the same views on the importance of moving on to other approaches, and I do believe that this is the next frontier in large vessel occlusion stroke treatment. More than just looking at whether that device or that device buys us another few percentages in reperfusion rates or time, I think the gains that can be made with other approaches are much larger. These are my disclosures. And as Matt mentions, there is a revival of this concept of neuroprotection. Why is that? We know that number one, the outcomes in thrombectomy are not that great. This is the Hermes data. It's a bit old, outdated. Maybe our outcomes nowadays are a bit better than what we saw in Hermes. 46% in the treated population. Maybe nowadays we'll do around 50% in all comers, 55%, but that's where we are. And I would argue that most, just like Marcelo said in his talk, I very, resonated with me, that remark about the tennis player, that, we think that a ranking 0.2 is a good outcome, but the patients don't necessarily believe that. And I would say that most of us here in the audience would not be happy with a ranking 0.2. It means you're not working anymore. It means a lot of major implications in terms of quality of life. Yet we still define this as a good outcome. I think we need to reconsider what a good outcome is. And if you look at the really good outcome, a ranking 0.1, we are at 25%. So we clearly need to do better, right? And that betterment will not come from another thrombectomy device. I'm convinced of that. So there's different approaches that we need to look at. One is systems of care. That's another talk in and of itself. But another one comes from how can we augment the effects of reperfusion therapy. I do believe that reperfusion is probably the most impactful measure we have at our disposal, but that doesn't mean that we shouldn't look for other approaches that give us even better outcomes. And I think that certainly neuroprotection is something that we need to reconsider. And why should we reconsider it? The neuroprotection has been the graveyard of stroke trials. As you can see here, 160 completed human trials, none of them successful. It's been just one disappointing story after another. What have been trying to do with neuroprotection? Well, extend the therapeutic window for reperfusion, minimize reperfusion injury, and enhance recovery. That's kind of what we try to do with neuroprotection. The problem is, the fundamental problem, and the reason why it's justified to revive this concept, is that all these neuroprotectants, and there may be have been some wonderful neuroprotectants that we passed the opportunity to show benefit. They were shown to work in very controlled animal experiments, like Matt Goonis showed in his presentation. He creates some very standardized, controlled model of MCA occlusion, and every single animal, every single neuroprotectant, every single strategy is studied in this very standardized model. But as opposed to what Dr. Goonis has done in his lab and many other researchers before him, when we go into the human world until now, all these trials that I've showed that were unsuccessful, they just took all comers. They didn't have any kind of consideration for the status of the vessel. There were people with small vessel stroke occlusion, no occlusion, open vessels, people who already reperfused, because the status of the vessel was never taken into consideration. So the most important driver of outcome has not been accounted for in all these studies. And now, with the advent of thrombectomy, we have a human model of reversible cerebral ischemia that can be applied and can reproduce the animal, the lab experiments that were done to establish the efficacy of a certain neuroprotectant. And I think that's the biggest difference. We now have the same kind of model that is being used in animal labs that we can apply to humans that we didn't have before. And that is why we should reconsider neuroprotection in human cerebral ischemia. There were other issues that were methodological flaws in the previous trials. One is that the treatment effect sizes were determined by infarct volumes, right? When we talk of this approach is efficacious in animals because it reduces the infarct size. But in humans, we use the disability scales as our primary outcome. And those two don't always correlate. So that's another, we didn't measure the same thing in animals and humans. And now the animal experiments are the methodology in animal experiments is getting smarter. The animal labs use now behavioral outcomes in these animals or measures of disability, et cetera, right? Stroke is most prevalent, as we all know, in the elderly population with multiple comorbidities, whether most of these trials just tested young animals. And there's been also publication bias. So that's kind of a review of an overview of the failed neuroprotectant drug trials that I was a co-author on, and we kind of summarized why these experiments, why these studies all failed, and why is it justified to readdress this issue. We need to also take into account, and that kind of ties into what Dr. Guni said about the cocktail of drugs, that the ischemic cascade is a very complex phenomenon. It's not only one mechanism of death. There's multiple mechanisms, and they all kick in at different time points. You first have excitotoxicity. You have these peri-infarct depolarization who kick in a bit later or almost at the same time. Then you have inflammation, which is a huge thing. That kicks in a bit later. Then you have apoptosis, which also kicks in later. So you need to address these mechanisms at the time when they're most relevant, right? So the timing of these drugs has perhaps not been the best, right? Depending on their mechanism. And sometimes, it's like a whack-a-mole. You hit the excitotoxicity, but all the other ones get augmented. And the end result is the same. So probably we're gonna need to hit all these mechanisms of injury at the same time, okay? And that's where the concept of cocktail comes. You address all these mechanisms at the same time. And that's very difficult because, as Dr. Guni said, when you do clinical trials, you can't use cocktails of drugs. The FDA was not gonna, regulatory agencies will not let you do that. So how do you actually prove these that a cocktail of neuroprotectant approaches works, right? This is again a recent review of neuroprotectant activities according to different drugs and approaches, and what the mechanism of injury they address. And ideally, we should give all these drugs to stroke patients. Probably would have more efficacy, but that's a challenge. We cannot do that from a regulatory standpoint. Another aspect that Matt has very nicely highlighted is this issue of fast versus slow progressors. Of course, we also need to take that into account, and perhaps it's something that we didn't add to our review, but it makes sense, right? Because fast progressors respond differently than slow progressors to certain interventions. And what is very important, again, the concept is that basically that's what we said when we wrote the paper about the fast and slow progressors in large vessel occlusion stroke, that when a vessel occludes in the brain, you have growth of infarct, and the infarct doesn't form the entire area supplied by the occluded vessel doesn't die off right away. It dies off in time. And there is a progressive growth of infarct until the entire area that is supplied by the occluded vessel has died off. And what we really didn't understand until recently was that this process occurs at different speeds in different individuals. The ones who have good collaterals or maybe other genetic predisposition, other factors that we don't understand that well, but there are these slow progressors. Those are the patients that drove the outcomes in the DAWN trial and diffuse 3 and all these late time window. They are slow progressors. They still have salvageable brain despite being hours after occlusion, right? And there's the fast progressors, unfortunately. Unfortunately, there are a lot of fast progressors. They don't have good collaterals or whatever else they're lacking that makes them very vulnerable to ischemia. They grow their infarct very fast. And we've seen that sometimes somebody has witnessed onset an hour ago, and we do a scan and it's just a complete wipeout. And the classic teaching is go back and find out from the history that can't be an hour. No, it can be, absolutely. That's a super fast progressor. Unfortunately, as interventionalists, sometimes we see that because we can cause an occlusion, and we know exactly when that happens. And sometimes we're unlucky and we see that even though we open up the vessel, the patient has a large infarct. That's a fast progressor. So one big task ahead in the neuroprotectant story is to transform all the fast progressors into slow progressors. As Matt said, buy some time, right? Different approaches. You can do that with drugs. You can do that with hypothermia. You can do that with collateral augmentation techniques. But the idea is that I'd like to see us 10 years from now or whenever, that everybody is a fast progressor, that when you call 911, EMS comes to you and you get this drug on board and you become a slow progressor. And then time is much less of an issue. You still need reperfusion because we know from DAWN and diffuse and all these late time trials that reperfusion is still necessary to prevent infarct growth, but you can slow down that infarct growth and you buy time until you go and open up the vessel with thrombectomy, right? So I think that's one of the holy grails of neuroprotection, transforming the fast progressors into slow progressors, ideally in the ambulance, at home, as soon as the sooner the better, okay? What's the prevalence of these fast progressor and slow progressors? When we defined a fast progressor as somebody who has a stroke volume of 70 cc's, which is about a third of the middle cerebral artery territory, within 6 hours, we thought that's a fast progressor. So if you infarct a third of the middle cerebral artery territory within 6 hours, that's a fast progressor. And we found in our paper that we published eventually that makes up about 25% of all stroke patients. Not that much, and then the rest are sort of another 25 are sort of intermediate. And then the slow progressors, which we defined as an infarct volume of less than 30 milliliters beyond 6 hours. That's what we defined as slow progressors. And that's about 50% of patients. And that's why there's actually a lot of slow progressors out there. That's why we could complete these DAWN and diffuse 3 trials ahead of time, because we didn't realize that they're so common. But still 50% of the patients are fast or intermediate progressors. So that's what we need to address before reperfusion with thrombectomy in terms of neuroprotection. How can we give these neuroprotectant drugs? Well, as I said, pre-hospital or pre-procedural, pre-reperfusion, a slow progressive cocktail. As I mentioned, that could be hypothermia, drugs, and collateral enhancing strategies. There are devices now that do that. We can give neuroprotectants intra-procedurally, like as you heard, hypothermia. We reperfuse the brain, or before we reperfuse the brain, we can infuse ice cold saline in the brain, or we can give these neuroprotectants intravenously or intraarterially during the procedure. If you, for instance, have a drug that only works on reperfusion injury, mitigates the reperfusion injury, it doesn't make sense to give it early before you reperfuse the brain. You give it after you reperfuse the brain, right? So depending also on the mechanism of action, you have to tailor the timing of administration to the mechanism of action. And then post-procedural anti-reperfusion cocktails, and very interestingly now, recovery-enhancing cocktails, recovery-enhancing strategies that we start learning more and more about, including, for instance, stem cells or other approaches that don't work on the ischemic cascade, but enhance recovery. How do we deliver those? Well, in the pre-hospital arena, it would be important to have something that doesn't require an IV, transdermal, intranasal, oral in stroke patients can be a problem because they can't swallow. Intravenous, of course, and then intraarterial, which has advantages and disadvantages. Now, in terms of cocktail, there is one approach that kind of covers it all. It works in all stages of cerebral ischemia, and that is hypothermia. If you look at the ischemic cascade, and I don't want to bore you with all these with the details, but hypothermia is a powerful neuroprotectant in the acute stage and also in the subacute stage. All these mechanisms that I mentioned earlier, hypothermia addresses them. But the problem is, as Matt Goonis said, that we have no idea whether it's him or Pat Lydon or whoever, nobody knows exactly. We haven't figured out the time window, the depth of hypothermia, how low should we go with hypothermia, the duration, and how we prevent complications, because there have the human trials of hypothermia have been disappointing. And a lot of that had to do with complications, pneumonia, things like that, infections. That's a real problem. And we need to figure out how to mitigate these complications. And as Matt said, this approach is very interesting because it may avoid the systemic complication and brings hypothermia where it is needed focally in the brain. And this is the group that has participated. We collaborated in Bauchi in the basilar occlusion trial. They kind of paved the way for the focal cooling experiments or approach in ischemic stroke. They've published a lot, and this is a meta-analysis mainly of their publications showing that hypothermia, local hypothermia with ice cold saline infusion works, reduces infarct volumes, and does so only when or mainly when combined with reperfusion. So in and of itself, it's not very effective, but combined with reperfusion, it is very effective. And as Matt mentioned, the challenge is to find the right catheter that maintains that cool saline over the length of 1.5 meters as the fluid traverses from outside to the brain, and maintain that the temperature of the fluid. This is another interesting drug. It's uric acid. It's a natural compound. There has been a phase 2 to 3 trial, a randomized trial that examined the role of uric acid in patients who underwent reperfusion therapy, intravenous and intraarterial. That trial was showed some signals of benefit, but it didn't quite make statistical significance. But there have been pre-specified sub-studies just having to do with the mechanism of action of uric acid. For instance, we know women have a lower concentration of uric acid, natural concentration. So the hypothesis was that uric acid will work better in women and in men, and that turned out to be true. The hypothesis was that uric acid will improve microcirculation in diabetics, and it turned out to be true. In subgroup analysis of this trial, Uric or Ictus trial, diabetics were found to benefit from more than non-diabetics from reperfusion therapy. And the most important to me such trial has been also a pre-specified subgroup analysis of Uric or Ictus trial that was conducted in patients who underwent endovascular therapy. So endovascular therapy plus uric acid. And you can see here, the number was very small. There were 45 patients who were randomized, but the treatment effect were really, really strong. So statistically significant. Again, it's a very small number of patients, hard to make much out of it, but they're very strong signals of benefit of this drug. Another interesting approach is glyburide, intravenous glyburide, the diabetic drug, which works on a receptor in the brain that prevents edema formation. Now, this drug has been shown to work in large strokes after in the delayed time window to just reduce edema in large strokes. But I think that this would be a very promising approach early in the stroke, because edema is an important mechanism that leads to infarct growth. So if you give it early, you could potentially transform fast progressors into slow progressors if you give it early and mitigate the effects of edema. And then the sphenopalatine ganglion stimulation is a trial that almost reached significance, very strong signals of benefit. This is a collateral augmentation treatment. You insert a needle in the sphenopalatine ganglion. That was done by a neurologist or ED physician. It's relatively easy to do with a time window of 24 hours after stroke onset. And this kind of improves collateral flow to the brain. And in patients with cortical stroke, this has been shown to make a statistically significant difference in the rate of outcomes between treatment and control patients. So that's another sort of promising approach. So because of this revival of neuroprotection in combination with stroke, there's so many drugs that showed promise. The NIH decided to take a methodical approach to this problem and selected 6 drugs, 6 approaches based on rigorous preclinical data. So these approaches had to fulfill certain criteria, and launched this program called the SPAN, Stroke Preclinical Assessment Network, which is a network where these 6 drugs and future others in the future were tested very rigorously in a completely blinded manner in all sorts of experiments, including all types of animal, young, old, comorbidities, behavioral outcomes, etc., at multiple centers. And I know that the result of this giant experiment is now known to a very small group of people. We don't know yet. It's going to be probably reported in a couple of months. I know there is at least one winner, one drug that has shown very powerful neuroprotectant properties and made the cut for what probably will be human trials combined with reperfusion. So stay tuned to that. A couple of words about the nerinatide. I think Matt mentioned this. This was a very important trial, the combination of reperfusion with the neuroprotection for a drug that works in the excitotoxicity in the very early phase of the ischemic cascade. There were some interesting preliminary studies showing efficacy. This is sort of how it works, as I said, in the excitotoxicity phase of the ischemic cascade. And this trial, which was completed and reported and published, included about 1,100 patients matched in terms of demographics. The patients received either placebo or drug around the time of reperfusion therapy. I don't know if you guys were a part of it. I think you were. We were as well at UPMC. It was very exciting, but it was not so exciting to hear the actual results. Overall, this trial was negative. But it turns out, so no difference between the two groups. But it turns out, as Matt Gunis mentioned, that TPA inactivates nerinatide. And these are some blood samples from patients enrolled in the trial showing that in patients who received intravenous alteplase, the blood level of nerinatide of the drug was much lower than in the ones who did not receive alteplase. So in fact, if you just looked at the no alteplase, no intravenous TPA patients, there was actually a very solid treatment effect, statistically significant, about 10% treatment effect on the ranking 0-2 between nerinatide and placebo, paralleled by mortality reduction and reduction in infarct volume. So because of that, of course, the trial was negative, but this finding encouraged the investigators to launch the second part of the continuation of this trial, which is called Escape Next, that enrolled patients only patients who did not receive intravenous TPA. This trial is almost done, and I hope it will be presented in February at the International Stroke Conference. So anyway, very exciting news there. Again, going back to this concept of giving the neuroprotectant very early in approaches that make sense, like excitotoxicity, collateral enhancement, oxygen carrier, as Matt showed, it is critical that it's being done as quickly as possible. And from that standpoint, what I was really excited about, and that was 2015, was to see that it is in fact possible to give drugs in the ambulance. This is the FAST-MAG study was done in Los Angeles County, and most patients in this trial received magnesium sulfate as a neuroprotectant, which didn't work, but it doesn't really matter. What to me, what was relevant is that you can organize a trial, you can make these treatments be available in the golden hour, the first hour after stroke onset, like in the FAST-MAG. And then nerinatide has a parallel trial called Frontier trial, where again, patients are being randomized and administered the drug in the ambulance. That's a trial that is ongoing in Canada. I'm very excited to hear the results of this study. The median time from onset to drug, stroke onset to drug in this study is around 50 minutes. So that's, again, proof of concept that you can give this drug in the ambulance, and this is what we need to see in the future. So in conclusion, I don't think neuroprotection is ready for prime time yet. We need those randomized trials. But the advent of reliable reperfusion therapies for proximal large vessel occlusion justifies a reappraisal of neuroprotection combined with endovascular reperfusion, mirroring the model of reversible MCA occlusion that we see in animals. So stay tuned. I'm convinced that in the future we will combine neuroprotectant strategies with endovascular reperfusion. Thank you.
Thank you, Tudor. Yeah, we are part of Escape in A1 and Next, and we're also collaborating with Italo. He has a oxygen carrier.
Yeah, I know it. I know it. That's also very promising.
Chimera, very much earlier phase, but I totally agree. I think it'd be great to these places that are 2-3 hours away, that we can slow the progression and allow for the transportation. Any questions to Dr. Can we bring the microphone there, guys, please? Thank you.
Aqui ainda, ficar o dia inteiro. Já,
Thank you.
claro.
You mentioned about the uric acid treatment as a possible treatment. Is this the same uric acid we're measuring in our gout patients? And if so, has anybody looked to see if there's any difference in the evolution of a stroke in treated and untreated gout patients whose uric acid levels are going to be quite a bit different?
Yeah, that's a great question. So there have been studies looking at levels of uric acid and outcomes in stroke. And lo and behold, there is a positive correlation. Not necessarily gout patients, but uric acid levels, higher uric acid levels seem to have a protective effect. The patients do better.
Thank you. Any other questions?
So, thinking about cocktail and all that, so what do you think? I mean, there's people who routinely will inject a bit of verapamil. I mean, in Europe, a lot of people now use TPA. I mean, we'll have tendency to think about fancy new stuff, but what about studying those things like verapamil, for example? Anybody's thinking about just...
There have been studies of verapamil, of calcium channel blockers early in stroke, and not much in the way of signals of benefit.
But
and
again,
nitroglycerin too.
Yeah. For intervention?
Not for intervention, yeah, early in stroke. But, I mean, I think that's why there's so many drugs or compounds or approaches that's why the NIH has taken this systematic approach and has studied very rigorously, first selected approaches that had some preliminary data that met certain criteria, very rigorous criteria, and then went on to test them to see whether the preliminary data was reproduced by these very rigorous blinded trials. And as I said, I know there is at least one winner. So I think that that's probably gonna be a priority for the NIH to study that drug, because they spent so much on trying to find what are the best neuroprotectant strategies. But things may get a bit complicated because say NA1 is positive, then the benchmark will be reperfusion with NA1. It's your control group is going to be different. So it's a very dynamic, very fast moving situation. Sorry?
The Korean.
Yeah, there's a drug in Korea. I forgot the name. There's so many now. It's an explosion, and that's only what we know about.
I know this may not matter, but the mobile stroke units, do you see any role for them on the choosing which patients to be treated? Are any treatments that would be a contraindication to give if you have a hemorrhage, things like that?
Yeah, I think that I think that the biggest benefit for mobile stroke units is going to be trials. I agree with the speaker from yesterday, who I think was the director of EMS, right, Dr. Bradley. Yeah, that here in this community, there's not that much of a role for it. I think there's no question it is effective, probably for patients who don't need thrombectomy, makes sense. But I don't know that it's so cost effective. In other words, it costs about 1.5 million to buy and another $1 million to maintain per year. The question that I have in my mind is, if I had this money and spend it on programs to improve stroke care, would I get better outcomes? That's something that is not clear in my mind. My guess is that the answer is yes. But I think for clinical trials, that is a very interesting approach. But I can tell you there are technologies being developed. I think eventually we're going to have a CT scan in a regular ambulance. That's really what I'd like to see, because I don't have a problem with a mobile stroke unit, but it delays transfers, it delays arrival to the hospital. So I'd like to see an ambulance with a regular device that can tell you if you have blood in the brain or not, and get TPA there. I think that'd be great. And I think that's where we need to move. And there are some companies that are exploring these kind of options.
Tudor, there is a question on Zoom. What about TPA? What I'm reading is that intra-arterial TPA during thrombectomy. I know you have a whole talk on that. Can you make a brief comment on that, using TPA in cases of incomplete mechanical thrombectomy?
Well,
or even complete?
Yeah, even complete, it turns out, I mean, maybe for reasons that and Matt also alluded to that, that there's a lot of sludging, there's a lot of impaired microcirculation. And all I can tell you is that this trial that was conducted on a very small number of patients, just about over 100, with initially incomplete reperfusion. But because of slow enrollment, they allowed inclusion of all patients, including the ones with pristine TICI3 reperfusion. And that trial was widely positive. It was a randomized trial, small numbers, very strong treatment effect. I'm not sure I necessarily believe the treatment effect, but it's the direction. I don't have any reasons not to, to doubt the validity of the results. So I think we're not there yet necessarily to make this standard, but do we need confirmatory trials to look at giving TPA even blindly after we do our reperfusion therapies? Absolutely. And that's sort of emboldened me, if you want, to to be a bit more aggressive with chasing after emboli that were not recanalized, like the TICI, the TICI2B greater than 66 with an distal M3 that I'm, not sure I need to go after it endovascularly, but yeah, you can infuse some TPA there.
Great. Sounds good. We'll break for lunch. We'll be back at 1:10, guys. Full hour. Thank you.